Hi guys, welcome back to my channel, Obgyn Guide Made Easy. Today we'll be discussing eclampsia. In the last video we talked about preeclampsia. Eclampsia, this is when preeclampsia is complicated with generalized tonic-clonic seizures. Generalized tonic-clonic seizures are also known as grand mal seizures. So this may occur in patients with preeclampsia or superimposed preeclampsia. You remember in the last video I said superimposed preeclampsia is new onset proteinuria in a chronic hypertensive patient. Pathophysiology. So the organ changes are the same as in severe preeclampsia, but the changes are just worse in eclampsia. What causes convulsions? The spasm of the cerebral vessels, which result into increased cerebrovascular resistance, which in turn results in reduced cerebral oxygen consumption, which results in anoxia. So this causes hypoxic injury to the cerebral vessels. There's also cerebral edema, which causes cerebral irritation. Cerebral dysrhythmia, this is where there's abnormal transmission of brainwaves. So cerebral dysrhythmia increases due to hypoxic injury and edema, and also because there's excessive release of glutamate. Is released when there's a hypoxic injury insult to the brain. So remember, glutamate is an excitatory neurotransmitter, which results in overexcitation of the nerve cells, okay? If you were to order an MRI on this patient, that's magnetic resonance imaging, you will see cortical and subcortical edema, infarction, and hemorrhage. This is due to the hypoxia, ischemia, and the edema. These cerebral pathological changes are the same that you see in a hypertensive encephalopathy patient. The clinical features are the same as we discussed in severe preeclampsia, just that in addition to that, the patient develops generalized tonic-clonic seizures, also known as eclampsia. Okay, so if the patient presents to you to the facility before they develop eclampsia, they might present with acute fulminating preeclampsia. This is severe preeclampsia with exaggerated reflexes and symptoms like headache, visual disturbance, epigastric pain, and liver tenderness. So this is a warning sign that the patient is about to develop eclampsia, so you need to take action. Eclampsia is common in the third trimester. It can occur in antepartum period. This is before onset of labor. Most commonly occurs in antepartum period, about 50% of the cases. It can occur in the intrapartum period. This is during labor, and postpartum period. This is after labor. So about 30% of cases will occur in intrapartum, about 20% postpartum, and about 50% antepartum. There is 4 stages of eclamptic fits: the premonitory, the tonic, clonic, coma stage. Okay, but remember that the patient might not present to you in this order because they might have fitted from home on their way to the hospital, or no one observed them fitting. The premonitory stage, this is where the patient becomes unconscious. There's twitching of the muscles of the face, tongue, and limbs. The eyebrows roll and become fixed. This stage can last about 30 seconds. The whole body goes into a tonic spasm. There's stiffening of almost all the muscles of the body. The limbs are flexed and the hands are clenched. Respiration ceases and the tongue protrudes between the teeth. Cyanosis can appear. Eyebrows become fixed. This stage lasts about 30 seconds. In the clonic stage, there's alternate contraction and relaxation of the voluntary muscles. The twitching starts in the face, then involve one side of the extremities, and then the whole body is involved in the convulsion. Biting of the tongue can occur. Breathing is labored, and there can be blood-stained secretions. Cyanosis gradually disappears. This stage lasts about 1 to 4 minutes. The patient will go into a brief unconscious period, but some patients will actually convulse through the coma. And after waking up, they appear to be confused and usually don't remember the recent events. The fits are usually multiple, recurring at different times. After convulsions, you might notice an increased temperature, increased heart rate, increased respiratory rate, increased blood pressure, and increased proteinuria. But there will be reduced urine output and increased uric acid. This is because there's renal dysfunction, so there's reduced renal clearance of uric acid. So there's retention of uric acid in the blood. Status eclampticus. This is a worst scenario and it's associated with poor prognosis. The fits occur in quick succession with almost no recovery period between the fits. Differential diagnosis. These are some of the conditions a patient can have aside from eclampsia. The typical presentation of these conditions are history of fainting, fitting or in a coma state or altered level of consciousness. This can be confusion, agitation, history of a headache associated with projectile vomiting. So the patient could be non-epileptic. Hysteria, yes, you'll be surprised what a woman can do to seek for attention. So the typical presentation in a hysteric patient is over-exaggerated fainting, exaggerated fitting. The patient might have encephalitis. This is inflammation of the brain, could be a viral, fungal, or bacterial cause, meningitis, or puberocerebral thrombosis. Now, remember, pregnancy increases the risk of thrombosis at least 3 to 4 times than an average person. Remember, pregnancy is a hypercoagulable state. This is because there is increased levels of fibrinogen, thrombin, and clotting factors in pregnancy. Now, high-risk patients who can develop a deep vein thrombosis are obese patients, diabetic patients, hypertensive patients, patients who are using oral contraceptives, estrogen-containing contraceptives for a long time, and patients who've been immobile after birth, especially cesarean patients. Now, this risk is also present in the puerperian period. The puerperian period is the time from the delivery until 6 weeks after birth. Thrombus can dislodge from the femoral vein into the inferior vena cava and into the brain. Cerebral malaria, drug intoxication, or a space-occupying lesion. Now, I've noticed where there's absence of previous history of convulsion, but there's presence of edema, hypertension, proteinuria, fits, or a coma during pregnancy or soon after or in the puerperian period. Manage as eclampsia. In doubtful situations where you're not sure of the diagnosis, it's better you keep the patient in the obstetric unit until you come up with the complications of eclampsia. In the central nervous system, you can get cerebral edema, which can result into increased intracranial pressure, cerebrovascular accident, also known as a stroke, neurological deficits. In the eye, partial or total blindness. This is due to retinal detachment or occipital lobe ischemia. You can get injuries from the convulsions like tongue bite, fractures. In the respiratory system, you can get a pulmonary edema, pulmonary embolism, acute respiratory distress syndrome, or pneumonia. The pneumonia is due to aspiration pneumonia or hypostatic pneumonia. Cardiovascular system, you get acute left ventricular failure, cardiomyopathy, liver failure, renal failure, get suprarenal gland failure, hematologically get thrombocytopenia or disseminated intravascular coagulation. Placenta, you get accidental hemorrhage, also known as placental abruptio. You can get a postpartum hemorrhage. The fetus, you get prematurity. This is due to spontaneous labor or induction of labor. You get intrauterine fetal demise. Remember, there's uteroplacental insufficiency. You get intrauterine asphyxia. Also known as fetal distress. And then you get trauma. This is in second stage when assisting delivery. In the postpartum period, you can get puerperosepsis. This can be due to aspiration pneumonia or bed sores due to prolonged immobilization. You can get a puerperopsychosis. You can also get deep vein thrombosis due to prolonged immobilization. So these are the complications you get in eclampsia. Management of eclampsia, it's important to stabilize the patient first before taking detailed history and examination. While stabilizing the patient, you can take a quick history from the relatives like gestational age of pregnancy, the gravity, the parity, the age of the patient, and the number of feet and duration of feet, if they received any medication from home, if the patient is a non-epileptic patient. Then you move on to a quick examination. Remember to call for help. You need all the help you need. You can assign different people to do different activities, like someone to prepare medication for the patient, someone to cannulate the patient, someone to collect the blood, someone to catheterize the patient. Check the airway and maintain it. You can put a tongue blade between the teeth of the patient to make sure that the tongue does not fall backwards. Check for spontaneous breath, respiratory rate, and oxygen saturation using a pulse oximeter. Remember that oxygen saturation is supposed to be above 94 to 100%. Now, regardless, even if the patient is saturating between 94 to 100, maintain them on oxygen using a face mask at 8 to 10 liters per minute to avoid respiratory acidosis. Remember that these patients are vulnerable to hypoxic ischemic injury. If the patient has vomitus and secretions in the mouth, remove them by suction. Circulation. Check for the blood pressure, the pulse, the capillary refill time. At the same time, put up an IV access. Cannulate the patient. Put 2 large bore cannulas, one on the other hand and one on the left hand. Collect blood for full blood count and differential count. Remember, in severe preeclampsia, we discussed that the patient can have HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count. So you're looking for hemoglobin, low red blood cell count, and low platelet count. And also the white cell count, the differential count, if there's neutropenia, neutrophilia. Remember, I said that you need to think outside the box. What if the patient doesn't have eclampsia? It could be meningitis, or there could be a foci of infection somewhere, sepsis. So you look at the white cell count as well. You can also collect blood for group and cross match, 3 units whole blood, and fresh frozen plasma. Remember, these patients are at risk of hemolysis, disseminated intravascular coagulation, low platelet count. That is why you need your fresh frozen plasma, whole blood. Collect bloods for liver function tests. Remember, we said hemolysis, elevated liver enzymes. So you're looking alanine transferase, aspartate transferase, bilirubin, lactate dehydrogenase. Yep. Urea creatinine for renal dysfunction. Rapid diagnostic test for malaria and malaria parasite slide. Remember, cerebral malaria is a differential diagnosis. Rapid plasma reagent for syphilis test, because of syphilitic meningitis, can also present with fitting. This is a late feature. In a patient where you are suspecting that they are immunocompromised, like retroviral disease patient, collect bloods for serum cut. This is cryptococcal antigen test. Cryptococcus is a fungal infection that can cause meningitis. It's common in immunocompromised patients. Also collect blood for serum TAT. This is toxoplasmosis antigen test. Toxoplasmosis is a parasitic infection that can cause also fitting in patients who are immunocompromised. Protect the patient. Put the patient on the left lateral position, also known as the lateral decubitus position. This is to prevent aspiration. Put the patient in a rail bed to avoid the patient from falling off the bed, or put the patient on the floor because you want to avoid injuries in this patient. Start these patients on magnesium sulfate. Magnesium sulfate, there's the loading dose and the maintenance dose. In the loading dose, it's 14 grams, which is 4 grams given intravenously and 10 grams intramuscular. The 10 grams, you divide it 5 grams in one buttock, 5 grams in the other buttock. The maintenance dose, you continue giving magnesium sulfate for 24 hours after the last fit or after delivery, whichever is longest. So if a patient, let's say, delivered at 12 hours but fitted at 14 hours, so you continue giving 24 hours from this time. The maintenance dose is 5 grams intramuscular every 4 hours. given in the buttock, you alternate. Magnesium sulfate is the drug of choice in eclampsia. It stops feeding and prevents further feeding. It is a neuroprotector. What it does is it blocks sensitivity to acetylcholine and also blocks neuronal calcium influx. Remember, calcium and acetylcholine are responsible for feeding. Other advantages associated with magnesium sulfate are that it improves cerebral vasodilatation. Remember, in preeclampsia and eclampsia, there's vasospasm of the vessels of the body. So it causes hypoxic ischemic injury to the vessels and to the organs. So by dilating the vessels, it improves blood supply to the organs. It also causes dilatation of the uterine arteries, which improve blood supply to the placenta. It also increases production of prostacyclin. Prostacyclin, also known as prostaglandin I2. Remember in the last lecture, I said prostaglandin I2 causes vasodilatation and also inhibits platelet activation, preventing disseminated intravascular coagulation. The benefit on the baby is that it has no harm on the fetus. It does not cause CNS depression or fetal distress. Watch out for magnesium sulfate toxicity. The parameters to watch out for are respiratory depression. A respiratory rate of less than 16 breaths per minute is worrisome. Urine output of less than 30 mL in an hour. And loss of tendon reflexes. When you notice this, give calcium gluconate. This is the antidote of magnesium sulfate, 1 gram over 10 minutes. Put the patient on antihypertensives. Commonly used antihypertensives that are safe in pregnancy are labetalol, nifedipine, methyl-dopa. So you can give these drugs alone or together depending on how high the blood pressure is. And if the diastolic blood pressure is more than 110, you give hydralazine. Hydralazine is 5 milligrams to 10 milligrams given every 15 to 60 minutes until the diastolic blood pressure is less than 110. Put the patient on a prophylactic broad-spectrum antibiotic to prevent infection from aspiration pneumonia. Commonly used antibiotic is ceftriaxone. Restrict IV fluid in these patients because they are at risk of pulmonary edema and acute left ventricular heart failure. So ideal is 1.5 liters in 24 hours. Never to go above 2 liters in 24 hours. Catheterize this patient to monitor urine output, especially for magnesium sulfate toxicity. Admit to special observation unit. Inform your senior. Now that you've stabilized the patient, you can now take a detailed history from the relatives and do a thorough examination. Remember to monitor the blood pressure, the pulse rate, the respiratory rate every 30 minutes and the urine output every 1 hour. Continue maintenance magnesium sulfate as long as there's no magnesium sulfate toxicity and continue monitoring the fetal heart. Once the seizures are controlled, consider the Bishop score. You deliver this patient within 24 hours. Remember in severe preeclampsia, I said the definitive treatment of severe preeclampsia or eclampsia is termination of the pregnancy because that is where in the placenta, that is where all the pathology is. So deliver the patient within 24 hours of admission. If there's a good Bishop score, you induce the patient, induction of labor. If the patient is stable but with a poor Bishop score, you can consider induction of labor because the patient is stable or a cesarean section. For vaginal delivery, assist with the second stage, vacuum or forceps. You assist with the second stage of labor to help the mother reduce the duration of labor because stress can also cause increased blood pressure. If the patient's gestational age is 26 to 34 weeks, give steroids. Remember I said steroids help in fetal lung maturity. Another way of reducing on the duration of labor, remember these patients are hypertensive and labor is a stressful condition. So stress causes raised blood pressure. So you want to reduce on the duration of labor for these patients. So augmentation of labor. This is the process of stimulating the uterus to increase the frequency, duration, and intensity of contractions. So this helps reduce the duration of labor. So in the rich active phase of labor, this is when the cervix is 4 centimeters dilated to full dilatation, which is 10 centimeters. You rupture the membranes. This helps with descent of the baby. And you put them on low dose oxytocin, which helps with uterine contractions. If the feet are not controlled and the cervix is favorable, this is a good Bishop's score. Induce the patient for vaginal delivery. But if the cervix is not favorable, there's a poor Bishop's score, take the patient for cesarean section. Use oxytocin for active management of that stage of labor. Do not use ergometrin because it is contraindicated in hypertensive conditions. It can aggravate hypertension. Indications of cesarean section in eclampsia: uncontrolled fits in spite of therapy, unconscious patient, poor prospect of vaginal delivery. This is a poor Bishop score. Obstetric indications like malpresentations. In complicated conditions like, let's say, recurrence of fits, and you've already given magnesium sulfate loading dose of 14 grams, you can repeat magnesium sulfate 2 grams IV bolus. And if they're still recurring, you can give midazolam or diazepam, whichever is available. Patient develops status eclampticus, call the anesthetist to give sodium thiopental and intubate the patient. Indications of intubation are uncontrolled seizures, aspiration pneumonia, persistent hypoxia. Patient remains unconscious in post-seizure period. If fits still recur, you use complete anesthesia. You can use a muscle relaxant. Make sure the patient is already intubated. Consider cesarean section. Cesarean section might be life-saving in these situations where you can't control the fits, but weigh the risk versus the benefit. In some situations, you have atypical preeclampsia or atypical eclampsia. This is development of preeclampsia or development of eclampsia without fulfilling the standard criteria, which is hypertension and proteinuria. These scenarios are preeclampsia or eclampsia less than 20 weeks gestation age. This is common in a molar pregnancy or in twin pregnancy. Or gestation hypertension without proteinuria, but the patient has symptoms of severe preeclampsia and the lab results are showing thrombocytopenia and increased liver enzymes. Or you can have a gestational proteinuria without hypertension but with symptoms of severe preeclampsia, thrombocytopenia, and increased liver enzymes. Regardless, treat this patient as severe preeclampsia or eclampsia. Phew. This is the end of our discussion on eclampsia. In the next video, I will talk about placenta preview. Don't forget to subscribe for more videos. Thank you.